The primary objective of intrapartum fetal monitoring is to identify and prevent hypoxic ischemic encephalopathy, brain injury caused by oxygen deprivation, without driving a surge in unnecessary operative deliveries. Cardiotachography, or CTG, is the standard tool for this surveillance. It is designed for high sensitivity, meaning it rarely misses a fetus in actual distress. However, it is plagued by poor specificity. For indeterminate or abnormal tracings, the false positive rate for actual fetal distress can reach up to 98%. Furthermore, the positive predictive value for neonatal acidemia is only roughly 30%. Most of the time, the alarm is sounding for a healthy baby. Because CTG frequently identifies distress where none exists, it cannot be used in isolation. It necessitates the use of adjunctive tests designed to exclude distress rather than confirm it. Once a clinician identifies a pathological trace, a secondary clinical algorithm begins. This decision tree is meant to clarify whether the heart rate pattern reflects a true emergency. Non-invasive options include the amniotic fluid index, Doppler ultrasound, vibroacoustic stimulation, and non-invasive fetal ECG. If these remain inconclusive, the primary invasive backup is fetal scalp blood sampling, or FSBS, which measures biochemical markers directly from the fetus. Using these tests effectively requires a shift in interpretation. We have to evaluate them based on their statistical power to rule out distress. The true clinical utility of an adjunctive fetal monitor lies in its negative predictive value. A high NPV provides the objective evidence needed to safely allow labor to continue. The amniotic fluid index, or AFI, is often the first systemic proxy used when a heart rate becomes non-reassuring. This landmark study shows the correlation between amniotic fluid volume and outcomes. An AFI under 5.0 centimeters is associated with a significant increase in fetal distress requiring cesarean delivery. However, the incidence of infants born small for gestational age remains statistically similar, regardless of AFI. Doppler ratios show a 0% sensitivity and a 0% positive predictive value for predicting subsequent distress. But despite failing to rule in distress, these tests maintain high specificity, 86.4% for amniotic fluid and 92.2% for Doppler. They are effectively rule-out tools. Vibroacoustic stimulation, or VAS, offers a different functional check by testing the maturation of the fetal central nervous system. By applying a startle stimulus, clinicians look for a corresponding heart rate acceleration. A reactive response is a strong indicator of intact neurological function and normal hearing. Non-invasive fetal ECG, or knife ECG, represents a more technical evolution, extracting detailed cardiac data from maternal abdominal noise. By mathematically separating the fetal heartbeat from maternal signals, knife ECG allows for the measurement of the QRS complex. This provides a real-time assessment of intrauterine growth restriction and cardiac health. These non-invasive tests offer functional reassurance, but their inherent lack of sensitivity often forces an escalation to invasive biochemical sampling. Fetal scalp blood sampling is currently the final invasive step in the adjunct chain, utilized when non-invasive tests fail to reassure the clinician. Historically, a scalp pH result below 7.20 has been viewed as a definitive signal for immediate operative intervention. A 2025 cohort study by Goddard and colleagues tested the diagnostic accuracy of this historical threshold using contemporary birth data. The results showed that FSBS has a remarkably low sensitivity of just 28.6% for detecting actual neonatal acidemia. However, the actual statistical utility is found in its high specificity of 85.5% and its high negative predictive value. This means that while an abnormal FSBS result is an unreliable predictor of harm, a normal result is a highly reliable way to identify an uncompromised fetus. FSBS is statistically a rule-out test. It fails as a definitive alarm for true systemic hypoxia. This raises a fundamental question. Why does measuring scalp pH fail to reliably confirm systemic hypoxia? The answer is found in the mechanics of fetal compensation, the evolved strategies used to survive temporary oxygen deprivation. Under normal conditions, oxygenated blood is distributed evenly across the fetal body, perfusing both central organs and peripheral tissues. When labor contractions restrict oxygen delivery, the fetus initiates a protective reflex to manage the stress. The fetus triggers peripheral vasoconstriction, physically shunting oxygenated blood away from its non-essential tissues. This shunted blood is centralized to maintain the perfusion of the brain, the heart, and the adrenal glands. In this compensatory state, the scalp is a non-essential tissue. It is actively deprived of blood flow to save the core. This means the acidosis measured during a scalp sample often reflects local tissue ischemia or edema. It does not necessarily indicate a systemic failure of oxygenation. By sampling the scalp during periods of stress, clinicians are attempting to gauge central health using the very tissue the fetus has already physiologically abandoned. The challenge remains the high sensitivity but low specificity of the initial CTG trace. Effective fetal monitoring requires us to stop treating any single diagnostic modality as an infallible alarm. A robust clinical framework pairs the high sensitivity of CTG for screening with the high specificity of tests like AFI, VAS, and FSBS to confirm well-being. Clinicians must always contextualize the biological system, recognizing the difference between peripheral stress and central collapse. Future monitoring technologies aim to bypass these peripheral limitations entirely. Non-invasive fetal ECG and advanced waveform analysis offer the potential to directly monitor cardiac and neurological health in the core. Improving intrapartum safety means moving beyond measuring peripheral proxies toward tools that can directly observe the fetal core in real time. The challenge remains the high sensitivity but low specificity of the initial CTG trace. Effective fetal monitoring requires us to stop treating any single diagnostic modality as an infallible alarm. The most robust clinical framework pairs the high sensitivity of CTG for initial screening with the high specificity of tests like AFI, VAS, and FSBS to confirm fetal well-being. Clinicians must always contextualize the biological system they are sampling, recognizing the difference between peripheral stress and central collapse. Future monitoring technologies aim to bypass these peripheral limitations entirely. Non-invasive fetal ECG and advanced waveform analysis offer the potential to directly monitor cardiac and neurological health in the core. Improving intrapartum safety means moving beyond the measurement of peripheral proxies toward tools that can directly observe the fetal core in real time.